Well, it really is a pleasure to be here. And I'd like to thank Al and Stan. I realize this is going to be a tough act to follow after hearing those stories, but hopefully I can talk about what's going on and where the hope is for actually developing and finding real cures for brain tumors. As was mentioned, I'm actually from here. When Al called me about this, I jumped at the opportunity to come home. And of course, stayed with my family last night, and there was the trip down memory lane, and so this had to be inserted in the talk, and that is back when I too had more hair. It's been a while. This is the team I'm with now, and actually this is a bit of an outdated photo. We're a bit bigger than this now. Ours is a very large multidisciplinary group focused on treating patients with brain tumors. That's all I do in my neurosurgery practice, and we actually have 5 neurosurgeons who only treat people with brain tumors, and neuro-oncologists, medical oncologists, and a very large team that helps support this whole operation, including our own patient support group headed by Kathleen Lupika, and the role of having a nurse doing that is just so incredible, so valuable. But we have a large team, including a large research operation. I'm going to talk about quite a bit of that today. And here's our approach, and that is the team approach. So now I'm going to talk about one of the therapeutics that we're actually very interested in, and one that may be ideal for CED, and that's this Toca 511, and Tocagen is the company. So gene therapy for cancer has been out there for a long time as a promising therapeutic. And there's been a lot of work with gene therapy, not only for cancer, but for other diseases. Many of the studies performed in brain cancer have been using what are called non-replicating vectors or viruses. So when you pass a cold from one person to another, that's because it's a virus that replicates. It makes copies of itself that are then released and spread. And that property of viruses to reproduce themselves has been genetically taken away, by genetic engineering, taken away from many therapeutic viruses because of safety concerns. And you can imagine you don't want your therapeutic virus to spread all throughout the body. You want it to just go where you deliver it. And so the first generation of these viruses were non-replicating. And so they were just used because they would be able to get into cells. Viruses can get into cells. So they were just used as a delivery mechanism. And that approach was found to be safe, but it was not terribly effective because they really wouldn't spread. And so the lack of efficacy was attributed to the inability to infect all of the tumor cells. We're now several generations past that and using replicating viruses that are engineered in a way to try to prevent them from getting into normal cells, and designed in a way to try to prevent them from getting normal cells, but can spread throughout tumor. And Toca 511 is one of those. So here is sort of what we consider to be landmark work in brain tumor virus strategies. So this was work done by Fred Lang at MD Anderson, where he injected one of those non-replicating viruses into a tumor and then went back a week later and removed the tumor and looked to see where the virus went to see if it was spreading throughout the tumor. And so all of this is tumor tissue here, around here, and here is the extent of the virus spread. So all this tumor here had no virus within it, did not have the therapeutic gene. This area did. That's great that he was able to deliver it there, but it's not going to be very effective, is it? But this was an important first step to be able to get to where we are now. The Tocagen uses a different type of virus that does replicate, and it infects proliferating cells only, cells that are actively dividing. What are the most actively dividing cells in the brain? Tumor cells. Otherwise, the brain doesn't have very many actively dividing cells. Also, it doesn't kill cells on infection. So the first replicating viruses, called oncolytic viruses, were ones that would reproduce so much that they would burst the cell. So they would infect a cancer cell, reproduce, burst the cell, and then that was it. The factory was shut down. Okay? The idea of these viruses is to turn the cells into a factory to produce more viruses. You destroy the factory, it's not going to be terribly effective. And what would happen is for a number of different reasons, there wouldn't be spread through the tumor. With this virus, it does not shut the factory down. It doesn't kill the cells. They keep producing virus and keep producing until you shut the factory down, and I'll talk about how that's done. Also, this is a type of virus that's not normally seen by humans, and so there's less likely to be an inherent immune response against it. And so the potential is for more long-term control, but it's still early stage, and I'll talk about the trials. Here is an experimental model of brain cancer showing a tumor next to brain, within the brain, and here's where the tumor has been infected with this virus carrying a marker gene, so you can see where the virus went, and there's really none of that in the brain. I realize there's a lot on the slide. Let me just tell you, it's delivering a gene. Ultimately, we want the virus to deliver a gene that is not present in normal cells. We call this a suicide gene. Okay, it's not quite a suicide gene because there's two steps to the process. It delivers a gene that's not normally present that will convert a non-toxic medication into a toxic one for the cells that are infected with the virus, the ones that are producing this gene. The gene is called a cytosine deaminase. It converts a drug called 5-FC, which really has very little in the way of side effects, into a drug called 5-FU, which is a very, very potent chemotherapy. So potent that it can't really be given in high doses to get into the brain. It's too much toxicity. So here, what the idea is to turn the tumor cells into a factory that produce the enzyme that will convert a non-toxic drug into a toxic drug within those cells. And this just schematically shows what happens. We inject the tumor, the virus, at least theoretically, spreads within the tumor. We then give the 5-FC, and hopefully the tumor regresses. This just shows some animal data, and again, we've cured lots of mice in the lab. Here's another example of curing mice with this approach. So we're now engaged in the first-in-man study of this virus. And you can imagine this took years of work with the FDA to get it to a point where it was considered to be acceptable to move forward with this trial. And I can tell you it took at least 6 months, if not 9 months, just to get it through our biosafety committee at the clinic. It's a lot of work to get this up and running. And I understand it's going to be up and running here in the near future. So these are adult patients who have recurrent high-grade tumors, grade 3 or grade 4. And right now, the tumor size is being restricted because we need to give the virus the best chance to spread to get a sense of whether or not this is actually working. At some point in the future, perhaps larger tumors will be included. And this cross-sectional area is roughly around a 3-centimeter tumor or smaller, maybe a little bit more. And then the usual sorts of things for going into a clinical trial. You cannot be completely immunocompromised. And Avastin is not precluded. It has to be out of the system in 6 weeks because it needs to be fully out of the system for surgery safety reasons, because this does involve a surgical procedure. And the surgical procedure is that we inject the virus into the tumor. So we do a biopsy and at the same time inject the virus in. Now, for the first pass at this, we're just using the biopsy needle to inject the virus. That is not an ideal approach. We actually do want to spread it out more completely within the tumor, which is one reason why Toca is very interested in the CED story as well. So after this has been injected, we wait 4 weeks. Nothing's going on. No treatment. It's letting the virus spread through the tumor, which is, again, one of the reasons why we start with smaller tumors, because nothing is being done in the way of chemotherapy or anything else at that time. Ideally, at that point, the tumor is spread throughout. The virus is spread throughout the tumor, and so at 4 weeks later, we start giving the 5-FC. And this is pills that are taken for 6 days. And then 4 weeks later, you take those pills again for 6 days. And this just keeps going on until there's evidence of progression on the MRI. The first trial, just like that autolytic trial I told you about, the first one, we have to make sure that this is not toxic, that this is not going to hurt patients more than it has potential to help. And so it's a dose escalation trial, meaning we start with a certain dose of virus and then we start going up from there. There are 3 centers involved, the clinic, UCLA, and UCSF. We have 6 patients treated to date. 3 have been fully evaluated in terms of the toxicity. And so far, it's been very well tolerated, both the virus and the 5-FC. We've had no dose-limiting toxicities, and there's been some suggestions of drug activity, although, again, I caution you not to read too much into that. We've just scheduled our teleconference to go over the latest 3 patients before we open up the next cohort, which is going to be the highest dose that we're going to look at.